We will discuss fracture both bone forearm, its treatment options in this discussion. Fractures of the radius and the ulna are common skeletal injuries in children. Distal fractures are easier to immobilize. They have a greater remodeling potential and they therefore require less intensive treatment. Proximal and distal radial nerve joints should be assessed to rule out fracture related articular disruption or the dislocation or subluxation. The wrist ligaments are strong and protect distal radial nerve joints. So, in children, the anatomy is protective against Gallagher fractures. Montage fractures are common because proximally the relation between the annular ligament and the radial ulnar places more strain on the elbow joint. Common fracture is torus fractures. Buccal or torus fractures are metaphyseal compression injuries with one intact cortex and no resulting angular deformity. These can be treated with a splint and a single follow-up visit at 3 weeks or a splint removal at home. Regular follow-up X-rays are not required in torus fractures. Criteria for acceptable reduction. This was published in Journal of Bone and Joint Surgery in 2006. Isolated distal radius fractures are accepted if there is an angulation of less than 5 degrees on lateral and anteroposterior radiographs and more than 90% apposition of the fracture on the lateral and anteroposterior radiographs. Combined distal radial and distal ulnar fractures are accepted if the angulation is less than 10 degrees on either AP and lateral radiographs and more than 50% of apposition of the fractures on AP and lateral radiographs. Isolated distal radius fractures are accepted as an acceptable reduction if there is angulation is less than 10 degrees on AP and lateral radiographs and more than 50% of apposition in both the views. Reduction of distal metaphyseal fractures in children is optional because it has a tremendous remodeling potential. A study of 51 children less than 10 years old who were treated with a splint and no reduction showed that after at least 1 year follow-up, the mean angulation was less than 5 degrees and all functional outcomes were excellent. Below elbow and above elbow casts give equal good results in the distal radius fractures. Complication rates are similar in both the type of plasters. Factors that are associated with high risk of loss of reduction include combined radial and ulnar fractures and residual angulation after initial reduction. Coming to the diaphyseal fractures. Close reduction and a long arm cast in girls with a skeletal age less than 10 years and boys with a skeletal age less than 12 years is sufficient. No need to do any intervention if the reduction is acceptable. What is the acceptable reduction? The angulation is less than 15 degrees and alignment of the proximal and distal radial nerve joint is acceptable and X-rays are acceptable according to the criteria. In this X-ray you can see fracture both bone forearms at the junction of middle to lower 2/3 and upper 1/3 and acceptable reduction and treatment with the above elbow cast. Coming to the surgical fixation. Surgery is very rarely done in children for the both bone forearm fractures. If the child is older or reduction not acceptable, surgical fixation should be carried out. Proximal third radius fractures are difficult to control non-operatively in older children. For surgical fixation, both the plates and flexible intramedullary rods are acceptable. Plates provide more control of the comminuted fractures, but they may be associated with higher complication rates and are more difficult to remove.